Kathy, you're on mute.
Thank you. Hello, everyone. My name is Kathy Flynn, and I'm the National Senior Director of Engagement for the American Liver Foundation. The American Liver Foundation is the nation's largest voluntary healthcare organization serving people with liver disease and those who care for them. Since 1976, we have provided a voice for patients and their families through education, support, research, and advocacy. Welcome to the third session in a series of nurses education webinars presented by the Greater New York and New Jersey Medical Advisory Council. This session focuses on liver transplant disparities in Black patients. These educational programs were planned by nurses, for nurses, advanced practice nurses, and other healthcare professionals. Today, I'm joined by my colleague, Alicia Epic, who will be handling the technology for the webinar. Alicia, would you mind sharing our disclaimer and a few words about the meeting platform? You're on mute now, Alicia.
Thank you, Kathy. So everybody signed a disclaimer online, but we just want to reiterate that this webinar will be recorded. Please note that by participating in this webinar/meeting, you will be participating in an event where video, photography, and audio recording may occur. We are recording as we speak. And then, so if you guys would just read the disclaimer really quickly, and then we can move on. And just some etiquette for Zoom, just so you know. We are recording on Zoom, so if everybody could just make sure that they are on mute. If you guys have any questions, all of our speakers will answer questions after each of the presentation, or after all three of the presentations during our question and answer portion. And I'll send it back to Kathy. Kathy, you're on mute.
I'll get this right today. Thanks, Alicia. The American Liver Foundation is grateful for the support that it received from ASI and Gilead Sciences for this educational webinar. Thank you to Maria Estrella Espinal from ASI Oncology and John Spellman from Gilead Sciences, who are here with us today. At this time, Maria Estrella Espinal from ASI is going to share a few words. Maria, are you with us?
Yes, I'm sorry. Hi, hello everyone. Thank you for having us today. We're very happy to be a part of this foundation, and hopefully in the coming years we'll continue to be a part of it. So I'm Maria Estrella Espinal, and I represent New York City, and I represent those patients of first-line treatment for hepatocellular carcinoma. So yes, I'm happy to be here today. Thank you.
Thanks so much, Maria. And now it's a pleasure for me to introduce to you Dr. Emmanuel Emeasoba from the Starfish program at Montefiore Hospital, who is going to speak on behalf of Gilead. Dr. Emeasoba?
Hello, everyone. Good afternoon. Thank you for the opportunity to speak at this wonderful event. My name is Dr. Emeasoba. I work also with the Starfish program at Montefiore. And so I just wanted to say a few words about, the liver transplant disparities in Black patients. So obviously, one of the reasons why liver transplantation is important is because we do that in people with end-stage liver disease, right? Which is a major cause of morbidity and mortality, amongst ethnic minorities. With ethnic minorities, obviously, we talk about the Hispanics, Asians, and the Black community, right? So data has shown that like 30% of all, that ethnic minorities comprise approximately 30% of all adult liver transplantations. So if you look at the data from like United Network of Organ for organ sharing, you'll see that according to that data, the cause of liver disease is different in different populations. When you talk about the Black community, which is the reason why we're having this talk today, you talk about things like hepatitis C virus, hepatitis B, alcohol, liver cancer. These are reasons why we do liver transplantation. So we personally think from the Starfish program, we think a lot of reasons why we think there are some disparities in the Black communities, because the time of diagnosis is very important. Like if the diagnosis of liver failure is not made on time, then transplant would not be on the table. So basically, because I remember one time we had a patient at Montefiore, and the patient was being treated for liver cancer and was taking medications because the patient had a liver cancer which was caused by hepatitis B. And the patient didn't even know what he was taking medications for, which was really bad. So, and also we also think that part of it's also due to understanding of the illness as well as language barrier, which might also play a role in these disparities in Black community. So which is why awareness is very, very important, which is what the Starfish program does. So what the Starfish program does at Montefiore is that we go out to the community, we talk about hepatitis B and how it causes liver cancer. And so we invite people for free screening. We screen them, and then we detect people who have chronic hepatitis B on time. And then we link them to care and also to our hepatologist at our institute. So in that way, they at least they have a quicker access to the liver transplantation as well. So basically, bottom line is screening is very important. If you don't screen people, if people don't know what they have, then they cannot take care of themselves. Another reason why we think there's disparities in the Black community is because of, there's also the socioeconomic status, the health insurance that plays a role. According to National Healthcare Disparities Report, commercial and private insurances are more likely to be referred for liver evaluation, for liver transplantation. So, and obviously we know that there's a lower socioeconomic status in the Black community. So that might also play a role. So, so basically, when you refer a patient faster to the transplant center, then increases the likelihood that the patient might get evaluated. So, and lastly, if once you complete the evaluation of the liver evaluation, and you are being added to this network, the United Network for Organ Sharing. So most times, once you're on the waiting list, we don't see any significant ethnic differences that kind of affects the waiting list outcomes. So in the Starfish program, we concentrate more on the screening of these of people. So what we do is that we go out to the community, we speak to the community, and so we tend to create awareness so they understand one aspect of the causes of liver cancer, which is the hepatitis B. So when they understand that, so we bring them to the hospital, we screen them, and if they are found to be positive for chronic hepatitis B, then we link them to care, especially if they are not already getting the care that they need. And if they're found to be negative, then we tend to vaccinate them to prevent them from getting hepatitis B virus. And if they already have the disease or they're lost to follow-up at some point, then we link them to care. And we also found that a lot of patients that we've seen at Montefiore, many of them who came to our screening, who we thought we spoke to and they came out of their own will, had some, I think almost like 40% of them had hepatitis B virus, even the chronic form diagnosed back in the day, but just that they never followed up because they didn't understand what the diagnosis was. So which is very important. So so the bottom line is screening is very important. Knowing the age to get screened for liver cancer is very important, and knowing the age to get screened for hepatitis C, all these risk factors that kind of affect your liver and end up leading you to require liver transplant. So knowing when to screen and how to screen, and being aware and understanding what's going on in your life is really, really important. So that's all I wanted to share with you. So I just wanted to share what the Starfish program is doing, which is basically engaging the community about hepatitis B and how it affects your liver, and also trying to create more awareness and screen every single African in our community. Thank you very much.
Thank you so much, Dr. Now it's my pleasure to introduce to you today's moderator, Margie Fernandez-Sloves, a chief nurse practitioner at the New York Presbyterian Hospital, Weill Cornell Medicine's Division of Liver Disease and Transplantation. Margie earned her doctorate in nursing from Columbia University in 2007. She started her career in liver transplant at Mount Sinai in the 1990s and has been with New York Presbyterian for almost 18 years. After 13 years at the Columbia campus, she moved to the Cornell campus in 2016 to assume the position of chief nurse practitioner. Margie is a clinical faculty member at Columbia School of Nursing and an active member of the American Liver Foundation's Greater New York and New Jersey Medical Advisory Council. So Margie, I'm going to hand the program over to you. Thank you very much.
All right, thank you, Kathy. Good afternoon, everyone. Thank you for joining. I see we have quite a few people registered, which is very pleasing to see. Today's Nurses Education Program will feature a presentation by a panel of 3 nurses from Columbia University at the New York Presbyterian Medical Center, followed by a question and answer session with them. Our featured speakers are Nicole Golden, Monica Nelson-Kone, and Veronica Roy. Together, the 3 nurses created the Black Transplant Health Initiative at New York Presbyterian in collaboration with Columbia and Cornell University and Medical Center. They're aimed at increasing access, awareness, and advancement to organ transplant within the Black community. Nicole Golden is a family nurse practitioner who earned her doctorate degree in nursing practice from Columbia University School of Nursing. Her career spans over 20 years, with most of her experience predominantly in acute and intensive care settings. For the past 10 years, she has held the role of clinical coordinator at the Center for Liver Disease and Abdominal Transplantation at Columbia University Medical Center. She is also a member of the clinical faculty at Columbia University School of Nursing and one of the American Association.
Thank you so much, my dear. Webex, Zoom,
I'm sorry. Sorry. Okay, back to Nicole. So she is also a member of the clinical, of the American Liver Foundation's newest member of Greater New York and New Jersey Medical Advisory Council. Monica Nelson-Kone is a registered nurse and a transplant coordinator at the Center for Liver Disease and Transplantation at New York Hospital. She's been in the field of organ transplantation for over 10 years. Her initial years in the health field were spent in community health nursing. She is a co-founder of the Black Transplant Health and Liver Health Initiatives, which is seeking to increase access, awareness, and advancement to transplant for Black patients through multiple avenues. She is a champion for her local community and the hospital community at large. Veronica Roy is also a family nurse practitioner with over 14 years of extensive nursing experience. She recently received her doctorate in nurse practice degree in 2020, also from Columbia University School of Nursing, and has worked at as an adult liver transplant coordinator at the Center for Liver Disease and Transplantation at Columbia for the past 7 years. Her background includes pediatric critical care, as well as pediatric and adult emergency medicine. Veronica is passionate about health equity and increasing access and advancement to organ transplant for Black and Brown individuals. She belongs to several professional organizations, including Greater New York Black Nurses Association, National Society for Leadership and Success, and the American Association for Nurses. All 3 of our speakers are committed to improving health equity for all. And some of the topics that they'll be reviewing today are health equity, the role of structural racism in medical decision-making, barriers to transplant, adopting racial equity tools, cultural competent health literacy strategies, and patient navigation. Please remember that you may enter your questions for the speakers in the chat box, and they will answer all questions at the conclusion of their presentation. And finally, it is my pleasure to turn over the program to our expert speakers. Thank you.
Thank you, Margie. Thank you, Margie. Bear with me, everyone. I'm just going to share my screen. Sometimes that can be, wait, hold on.
Sure, and while Veronica is getting the screens up, please remember that if you have any questions, you can just ask them in the chat box and Margie will pose them to the speakers at the end of the presentation. Thank you.
Okay. Can you guys see my screen?
Yes.
Yes.
Okay. So thank you, Margie, for that wonderful introduction. My name is Veronica. And like Margie said, I'm joined by my two esteemed colleagues, Nicole Golden and Monica Nelson-Kone. Today, our discussion will be on disparities in liver transplant for Black patients. We have no relevant financial relationships to disclose. And just to kind of guide our conversation today, we've just listed a few objectives. We would like to discuss disparities in liver transplant. We will go over implicit bias and structural racism and how that impacts medical decision-making. We'll discuss the terms health equity, equality, and justice and how each one is used. We'll go over social determinants of health and how that affects liver transplant listing outcomes and access to wait lists. Then we'll go into barriers to transplant and some mitigation strategies.
The following governing bodies in organ transplant have all publicized statements supporting diversity, equity, and inclusion. And we will start with the American Liver Foundation. The American Liver Foundation pledges to expand our offerings in marginalized communities and to continue to treat everyone with the dignity, kindness, and compassion that is their birthright. ALF's vision is a world without liver disease. Until that day comes, they will continue to fight for equal access to healthcare and better outcomes for all people impacted by liver disease. And the American Society of Transplant Surgeons have developed the Boldly Against Racism campaign. The BAR campaign is a coordinated effort to directly address racism and promote permanent and positive change in diversity and inclusion. The intention is to continue to cultivate and maintain an environment that welcomes and fosters diverse persons, call out racism, and set ambitious and collaborative objectives.
Recently, there's been a lot of discussion about health equity versus health equality, but we think healthcare systems should strive for health justice. An equality approach is the even distribution of resources and assistance. An equity approach acknowledges and corrects for exploitation and oppression of today, as well as the past, and breaks down the unjust systems that have been built to benefit some people while keeping other people down. Basically, an equity approach are custom tools and resources to identify and address inequalities. But justice is what healthcare systems should strive to be. Justice is fixing the system to offer equal access to tools and resources. Essentially, justice is getting to the heart of the problem.
What is implicit bias? Implicit bias, sometimes called unconscious bias, happens when we allow our own attitudes, feelings, stereotypes, or beliefs to impact our judgment or understanding of other people. It's called unconscious because it isn't something we do blatantly. Rather, it is an involuntary process based on our own deep-seated thoughts. Implicit bias may be based on any number of characteristics ranging from race, age, social group, or appearance. Those are the ones you might suspect, but implicit bias can also be based on height, weight, marital status, children, disability, political affiliations, college attendance, and so much more. Some of these biases are born as early as childhood. Later, they may be strengthened by friends, entertainment, and even media reports. Some experts say that there are more than 150 various implicit biases out there.
In a systematic review on implicit bias in healthcare, professionals published in the BMC Journal of Medical Ethics in 2017, Fitzgerald and Hurst aimed to examine implicit bias in healthcare professionals. They reviewed 42 articles. 17 used implicit bias measurement tool, the implicit association test, which you may have heard of, to evaluate the biases in healthcare professionals. 25 articles used vignettes, clinical vignettes, to examine the influence of patient characteristics on healthcare professional attitudes, diagnoses, and treatment decisions. Of the 42 articles, 27 studies examined race and ethnic biases. 10 other biases were investigated, including those for gender, age, and weight. Significant findings were 35 out of the 42 articles found evidence of implicit bias in healthcare professionals. All of the studies that investigated correlations found a significant positive relationship between the level of implicit bias and the lower quality of healthcare. In 2011, Hilder and company sought to estimate unconscious race and social class bias among first-year medical students and investigate its relationship with assessments made during clinical vignettes. They used a combination of the association of scores on an established implicit association test for race and a novel IAT for social class with vignette responses. For this web-based survey study, they looked at a total of 211 medical students entering classes at Johns Hopkins School of Medicine. And so they concluded that the majority of first-year medical students at a single school had IAT scores consistent with implicit preference for white persons, and possibly for those in the upper class. However, overall, vignette-based clinical assessments were not associated with patient race or occupation, and no association existed between implicit preferences and the assessments.
In looking at the role of structural racism and medical decision-making, I'm going to read a letter to the editor. This letter was written to the American Family Physician, and it was from 3 physicians addressing an article that was written on the management of hypertension. So I'm gonna call out these doctors because this was bold work. Andrea Westby, Abiri Akah, and Jason Rico. And this was addressing an original article from the American Family Physician. So quote unquote, title, Race-Based Treatment Decisions Perpetuate Structural Racism. To the editor, American Family Physician is an excellent source of evidence-based updates and review articles. So we were surprised and extremely disappointed with the article on hypertension by Drs. Smith, Lennon, and Kolsgaard. The authors advocated for the use of race in guiding the selection of antihypertensive medications without acknowledging that race is socially constructed. This perpetuates the myth that people of different races are inherently biologically different and warrant different treatment regimens. Race is a socio-political construct that does not represent shared genetic ancestry. It is a way of categorizing people based on physical characteristics and assumed geographic ancestry. But racial categories are defined differently across societies and have changed over time. Politics and power guided the information of race as a concept, not scientific certainty. As such, using race as a biological category to determine medical treatment is bad science. We feel that this was a missed opportunity for the AFP to raise awareness about the insidious ways in which outdated assumptions about the biological basis of race permeate current medical practice. Race-based medicine is not benign. It perpetuates structural racism, therefore leading to inequalities in treatment and outcomes. Research has shown that mere mention of the racial prevalence of genetic diseases in scientific textbooks is associated with the belief that race influences intelligence, which raises concerns about the implications of race-based medicine. A 2016 study showed that medical students and residents who believed that Black and white people are biologically different rated the pain experienced by Black patients as lower than that experienced by white patients, and they recommended inappropriate treatments. The premise of basing treatment decisions on presumed biological differences in race, an ill-defined fluid concept, is flawed and at best directly harmful at worst. With AFP's commitment to evidence-based medicine, we expected better. And we'll talk a little bit more about race-based algorithms later on. Now we'd like to take a look at a study which was done by Ducal et al. So Ducal et al. Performed a detailed analysis of liver transplantation for hepatocellular carcinoma at Indiana University. A total of 1,032 charts were reviewed from 2000 to 2014 to assess the low transplant rate for Black patients. In a subgroup analysis of patients who were within transplant criteria for tumor stage at diagnosis, Black patients remained 54% less likely than their white counterparts to undergo liver transplant. Black patients were significantly less likely to undergo transplantation compared to white patients and were more likely to be referred for palliative care for HCC. 42% of white patients on Medicaid underwent transplant compared to 17% of Black patients on Medicaid. Multivariate stepwise analysis showed significant disparity between Black and white patients with regard to liver transplant. Another study by Fernetti in 2019 found that Black and Hispanics are the two ethnic groups that have the largest increase in incidence, but continue to have the lowest rates of curative treatment for HCC.
Addressing social determinants of health. It's important for improving health and reducing health disparities. Though healthcare is essential to health, it is a relatively weak health determinant on its own. Research does show that health outcomes are driven by an array of different factors like underlying genetics, health behaviors, social and environmental factors, as well as healthcare. While there is currently no consensus in the research on the magnitude of the relative contributions of each of these factors in itself to health, studies do suggest that health behaviors like smoking, diet, exercise, social and economic factors are the primary drivers of health outcomes, and social and economic factors can shape individual health behaviors.
Adler and Ye in 2016 took a look at how these social determinants of health affected the development of liver disease, access to the waitlist outcomes, and post-transplant outcomes. They looked at hepatitis C and NAFL specifically, and how social determinants of health have increased the likelihood of development of disease. In addition, HCC surveillance in lower persons with socioeconomical status and poor insurance is also seen. Increased distance from transplant centers, transportation, lack of early referrals, psychosocial barriers. There is considerable variability among donor service areas in the likelihood of transplant versus death on the wait list. As a way to mitigate this barrier, most transplant centers do allow and encourage patients to travel to a more favorable DSA to be listed. However, this option is only available to a small subset of high socioeconomical status patients who have the means to relocate or travel long distances on very short notice. Lower socioeconomical status is associated with an increased risk of death 2 years after transplantation. Poor health literacy is associated with unintentional non-adherence, which is a risk factor for death and graft failure post-transplant. Lower income and limited literacy are also associated with greater number of post-transplant hospitalizations.
So let's look at how all of that affects Black patients. According to the current US Census, Blacks and African Americans make up approximately 13% of the US population, making it the second largest ethnic group in America after Latino Americans. Patients from communities of color make up 60% of the national transplant waiting list, but only about 40% of the actual population. This means that communities of color, particularly Black people and Latino people, are overrepresented on the waiting list. Part of the reason for this is that people of color have much higher rates of hypertension and diabetes, which puts patients at higher risk for organ failure. This slide basically depicts the average number of days that patients wait for a transplant. In most cases, white Americans are likely to wait fewer number of days for an organ transplant than Black Americans. And this identifies all of these solid organs, minus the pancreas. Oh, the pancreas is there. The data that is displayed here was pulled from the OPTN website, and it's current as of February 2020. Looking specifically at ethnicity, Black candidates made up 28.7% of the national total wait list for all organs. In 2018, chronic liver disease was the 9th leading cause of death for non-Hispanic Blacks ages 45 to 64 years old. African Americans were about 60% more likely to have liver and IBD cancer than non-Hispanic white men. African American women are 40% more likely to die from liver and IBD cancer than non-Hispanic white women. As you can see in this illustration, the distribution of adults on the wait list for liver transplant by race, the trends have been consistent for well over a decade, with Black patients undergoing transplant at a much lower rate than white patients.
Kardashian and colleagues took a look at how the COVID-19 pandemic increased the existing disparities in liver disease and offered some recommendations to help mitigate those disparities and bridge the gap in health equity through addressing the social determinants of health, extending from the individual to the community and societal levels. Interventions at the individual levels include implementation of systemic screening for social barriers in hepatology practices to identify gaps in the care cascade. At the community and societal levels, interventions include creating collaborative partnerships with public health workers to expand healthcare across to the community, increasing funding for research in investigating the association of social determinants of health, health disparities, and liver disease, and also engaging in advocacy to support policy reform that tackles the upstream social determinants and addressing racism and implicit bias. Spiewak and colleagues conducted a retrospective study among 463 patients diagnosed with cirrhosis admitted from January 2013 to January 2018 to a tertiary care academic medical center to further assess the impact of racial disparities in liver transplant and chronic liver disease. A total of 43 individual patients with cirrhosis were identified, including whites with N at 241, Hispanics with N at 106, and Blacks with N at 50, Asian and Pacific Islanders with N at 27, and other with N at 39. A significantly higher proportion of Blacks and Medicaid insurance, a significantly higher proportion of Blacks had Medicaid insurance compared to whites, and Blacks had lower median income than whites. All groups received high quality cirrhotic care. Black patients had the highest mean total hospital admissions and the highest mean number of 30-day readmissions compared to all other racial groups. They concluded that Black Americans hospitalized for complications of cirrhosis may experience significant disparities in healthcare outcomes compared to whites despite high quality cirrhotic care, and that socio-economical factors may contribute to those disparities. In another study, Warren et al. Sought to correlate transplant center characteristics with patient access to the waiting list and liver transplant. Waitlist race and ethnicity distributions from liver transplant centers performing more than 250 transplants over this period were compared with those of their donor service area, as calculated from the 5-year US Census Bureau estimates in 2017. They found that non-Hispanic Blacks are underrepresented in liver transplant listing compared with center donation service area, whereas non-Hispanic whites are overestimated. Hispanics were also underrepresented on the wait list at the majority of the transplant centers. Predictors of disparity in listing include percentage of transplant recipients at the center who had private insurance, racial composition of the donation service area, distance of the recipients that the recipients had to travel to transplant. Thus, they concluded non-Hispanic Blacks are listed for a liver transplant less than would be expected. Improvements in access to adequate health insurance appear to be an essential part of diminishing disparities in access to this life-saving care. Another research article published in 2015 by Knoll and colleagues sought to investigate racial and ethnic disparities in access to and utilization of living donor liver transplant. They created an analytical file from the UNOS standard transplant and research files and identified all adult patients older than 18 years of age who underwent liver transplant at a transplant center that performed at least one living donor liver transplant. During the study period of February 27, 2002 to June 4th, 2014, that was study period. The study outcome was transplant type, and the primary exposure was race ethnicity as submitted to the UNOS by each transplant center on behalf of each patient. Just notably, UNOS does not differentiate between race from ethnicity. There were 35,401 adult transplant recipients who met the inclusion criteria. Of these, 2,171 received a living donor transplant. Living donor transplant recipients were significantly more likely to be white, to have cholestatic liver disease, private health insurance, and lower laboratory MEL scores, and to reside in a zip code with a lower proportion of residents living below the federal poverty level. Racial ethnic minorities are substantially less likely to receive a living donor liver transplant, even when waitlisted at a center that performs a living donor liver transplant, regardless of the etiology of the underlying liver disease. These differences are most pronounced among African Americans, but are also seen among Hispanic and Asian patients in this study.
The studies highlighted in this presentation show barriers to transplant, right? And so these can be categorized into 4 main areas: access, awareness, advancement, and medical mistrust. Medical mistrust remains a chronic barrier. African Americans' distrust of the healthcare system dates back as far as 1797, when Blacks were counted as 3/5 of a person. In 1932, the Tuskegee experiment, which is well known today, caused the death and disease of hundreds of Black men and women. Even more recent examples, such as in North Carolina, with the forced sterilization of African American women between 1933 and 1973. The Black community has valid reasons for medical mistrust of providers and the healthcare system. In this study, medical mistrust, perceived racism, and experiences of medical discrimination among transplant patients, published in the American Journal of Transplantation in 2017, the authors sought to identify how patients distrust in the healthcare system through perceived medical racism and previous encounters with medical discrimination. And those do contribute to health disparities among Blacks in African Americans. You can see some of the results of the studies here. Most notably, it was a 22-item survey. Most notably, it revealed 81% of African American patients agreed with the statement that read, "You'd better be cautious when dealing with healthcare organizations," compared with only 36% of white patients. Again, this study was from 2017. So this is kind of like showing just how prevalent medical mistrust still is amongst the African American community.
Getting access to organ transplant is often accompanied by several challenges, many of which can be attributed to factors like the state of an individual's living circumstances, their economic status, geographic location, and insurance status. As a result, many racial and ethnic minorities, such as African Americans, Latinx, and Native Americans, they must unjustly wait longer periods of time for a new organ or never receive one at all because of these barriers to care. Research has shown that these disparities are avoidable, especially with changes at the institutional level. At each point of the transplant preparation process, there are opportunities for barriers to occur as a result of a patient, or maybe it's the provider, maybe it's the community, and maybe it's the institution in and of itself. Together, these potentially create disparities in access. Patients with organ failure who experience poverty, for instance, may face challenges covering costs of their insurance copayments, especially when they do not have comprehensive insurance or private insurance. Limited knowledge of the benefits of transplantation can also affect patients' ability to access transplants. Patients who are unaware that transplant is even an option may not even complete the steps to get access to the transplant waitlist. Providers can also play a role in limiting access. For example, doctors may not provide patients with referrals that they need in a timely manner. Research leads us to believe that changing systemic problems will help address problems at all other levels.
So basically, we're going to take a look at some potentially biased algorithms, and these algorithms exist in multiple disciplines of medicine: cardiology, cardiac surgery, the Society of Thoracic Surgeons, endocrinology, urology, nephrology, obstetrics, oncology, and cancer surveillance, as well as the OPTN and pulmonology. These race-based algorithms continue to perpetuate the current problem. And, you know, we must take a look at the biased input that goes into these algorithms so that we can change the biased output. If we don't interrupt this process, then we can continue to operate in ways where Black patients may be still dealing with disparital care.
So this is the health literacy umbrella. And I like this because there was a article in the American Medical Association that defines health literacy as the patient's ability to obtain, process, understand basic health information and services needed to make appropriate health decisions. So systemic factors such as limited educational opportunities, racism, health system mistrust, and lack of culturally tailored health information and services are health literacy barriers for the Black community. There was a study that showed that health providers overestimated the health literacy scores of 54% of African Americans compared to only 11% of non-Hispanic whites. Additionally, low health literacy has severe implications on the US economy, costing us about $236 billion every year.
In the United States, there is no secret that there is a significant shortage of available donor organs. So this has required us as transplant professionals to hold simultaneous yet divergent roles as advocates for patients who are in need of a life-saving transplant and as responsible stewards in the allocation of these scarce donor organs. The figure that you're looking at now demonstrates how societal factors along with personal background and experiences of a treating clinician can form implicit biases and potentially influence the selection decision of a transplant candidate. In a retrospective study done by Jesse and colleagues, the researchers sought to determine whether listing for transplantation was influenced by socioeconomic status and race and ethnicity. They identified 968 patients with end-stage liver disease. 72.9% were white, 19.6% were Black, and 7.5% were designated as other. And they underwent transplant evaluation at a large Midwestern center between the years of 2004 and 2012. And so the results show that over half of these patients were listed for transplant, with the three most common reasons for not being listed being medical contraindications, patient may have expired, and psychosocial contraindications. The Black race, even when adjusting for those medical and socioeconomic statuses, were associated with a 26% lower odds of being listed and a longer time to listing decisions compared to all other patients. Shown here are the results of a Harvard study excluding patients from transplant due to social support, a national survey of transplant providers by one of my favorite studiers, Kelsey Berry, Dr. Kelsey Berry, and colleagues. And they addressed the effectiveness of the use of social support in determining transplant eligibility. And so they concluded that providers estimate inadequate social support, and they do that up to 20% of transplant candidates needing an organ are affected. A majority of transplant providers believe that social support criteria disproportionately impacted patients of low socioeconomic status. And so nearly half of the providers lack confidence in their current social support criteria. This data suggests a need to better define and determine how social support should be used in listing decisions to reduce disparities in access to transplantation.
So now that we've discussed the disparities in transplant, let's talk about some ways to mitigate the problem. The transplant community must commit to identifying psychosocial barriers that prevent Black patients from assessing the organ transplant wait list. So by adopting standardized universal psychosocial criteria, this figure here that we have listed up here from Lewandowski and Schillings shows both the potential for negative outcomes with the current state of practice, as well as the potential for positive outcomes if we took a new approach by standardizing the psychosocial process.
So now we're going to continue with mitigation strategies. So there are many tools that we can use to examine our own possible biases. One tool is the implicit association test that measures attitudes and beliefs that people may be unwilling or unable to report. The IAT measures relationships between different concepts, example, gender and ethnicity, and our subconscious assessment, example, good or bad. Many different IATs are available, including those for gender, ethnicity, and sexuality, just to name a few.
So what do, right? Action items. Our group, we do like to give you the basis, but we really want to leave you with things that you can do in your organization or take to the leaders in your organization to start this work of getting to a place of health equity in your organization. And so you can do this by adopting some of the things that you're seeing on the screen. What does that look like? Performing personal bias assessment tests like the Harvard Implicit Association test discussed here in this forum. And so the results can be discussed in groups led by qualified professionals. Organizations should seek to provide professional workshops for providers and staff. Leadership also, and those can be on structural racism. There are tons of information and providers available to do workshops on implicit bias, microaggressions. Staff and coworkers will need tools to use for reassessment as necessary. Investing in cultural competent research that respects the known historical consequence of medical mistrust and seeks to assess areas in our healthcare system that may be inequitable. We can engage in racial reconciliation and healing by investing in advocacy and allyship for health equity. Last but not least, we have to create sustainable policy changes aiming at mitigating racial disparities within our healthcare system amongst patients and those who care for patients with the goal of health equity and justice.
We must also acknowledge the important role of culturally competent health literacy strategies. Studies suggest that reaching African Americans with low health literacy is more effective when adopting culturally tailored, interactive, and community engaged health literacy approaches. This is based on the premise that health information is processed through multiple lenses, and interpretation of health-related concepts and images varies across cultures. Examples of culturally tailored innovative approaches are storytelling, using culturally appropriate graphics, which have been reported to have improved health literacy and many health conditions. Printed materials containing real-life stories, culturally appropriate concepts and images, and practical action-oriented steps are well received within the African American community. Health literacy strategies will vary based on age and educational levels, and the use of faith-based programs to improve health literacy has been found to be positive on health outcomes.
The use of the patient navigator can be instrumental in increasing access to transplant for high-risk populations as well. A patient navigator should be understandable, available, accessible, affordable, appropriate, achievable. All of these things are the opposites of the negative effects of social determinants of health, right? And so in a randomized controlled trial, Transplant Center Patient Navigator and access to transplantation among high-risk populations, Basu and colleagues, they investigated the effect of a transplant center-based patient navigator on waitlisting among a population of largely disadvantaged patients. The study suggests an increase in access to the waitlist for high-risk patients after the first 500 days. Patients with a navigator were over 3 times more likely to be waitlisted compared to patients without a navigator. But time from referral to waitlist was 126 days longer for the intervention versus the control participants. Researchers felt that this effect may be because this high needs population may not have otherwise been waitlisted without a patient navigator. Although a patient navigator did not reduce time to waitlisting, the intervention could potentially still help high-risk needs populations successfully access the waitlist by addressing frequent encountered barriers that may delay waitlisting, which are usually directly resulting in addressing social determinants of health. In addition, they found that patients assigned to a patient navigator had twice the number of living donor inquiries.
In a systematic review published in the Global Health Action Journal in 2015, which explored the role of community engagement in improving the health of disadvantaged populations, they aimed to study which methodological approaches had the greatest impact and effectiveness. Of the 24 studies included in the review, 58% were of good quality and showed community engagement positively impacted health behaviors, health service access, health literacy, and a range of health outcomes. The findings suggested that community engagement models can lead to improved health outcomes and health behaviors among disadvantaged populations. However, the gaps noted in community engagement suggested that the need for innovative approaches, such as partnering with local Black-owned businesses, barbershops, hair salons, historically Black colleges, Black social media, that's why I got the Black Twitter up there, local politicians, and churches.
So what you're looking at is the results of our own outreach that we did earlier this year. We partnered with a local church in the community of East New York and provided community outreach. When you're seeking to partner with an established group, in this instance, it was a local faith-based organization within a Black community, it is advised to poll the group to find out what the needs are first. And so this will ensure that the current needs of the group you seek to serve will be met. And so the group consisted of approximately 50 women ranging in age from 8 to 80. This was our group that we polled to figure out what they wanted. And so we developed the Black Health Revival series from that, which consisted of these 5 workshops that you see on the screen, given by providers in their field of practice tackling diabetes, fatty liver, heart health, living donation, COVID vaccinations. The first workshop on COVID vaccinations was timely in that there was a significant amount of hesitancy and medical mistrust in the Black community, mostly due to the lack of information and fear of the unknown. Over 150 participants attended, and it eventually resulted in this church community becoming a vaccine hub itself. And so another notable result, which we are very happy about, is the workshop on living donation, which also provided timely information, which resulted in a successful direct donation between members of that church community and opened the door for a donation database within that community in the future.
I guess I have to move on to the next slide, but I could talk about that for days. So we just wanted to highlight some of the works in progress. We're very well aware that there's so much else going on that we may not know about. And it was very, very good to hear about the Starfish program that Monty heads. So Monty's my old stomping ground. So I just gotta say that. So some works in progress. The African American Access in Transplant program, and that is at Northwestern Medicine by Dr. Denise Simpson. And then the Hispanic Transplant program, also at Northwestern Medicine, which is led by Dr. Carlos Casedo, also at Northwestern. And then our startup work here at New York Presbyterian, Columbia, Weill Cornell, with the Black Transplant Health Initiative. So we just wanted to end this part by saying, if not us, who? If not now, then when? We are so grateful that you all joined so that we could continue to do this work together. And we will now turn it over to our moderator and open up for questions. Thank you all so much.
Thank you.
Thank you,
Thank
ladies.
you.
I don't see any questions in the chat, but I do have a couple of questions set aside, and I think we have a few minutes to go over a couple. The first question is, how can we add or enhance our training activities to ensure that staff and management share a common understanding of the complexities of health inequities and the skills that we need to advance health equity in our work?
So I can start off with that. I can take that one. So I think it starts with first acknowledging that we have a ways to go, and acknowledging that there are disparities, and speaking with leadership. It's very important to get buy-in from leadership to help create programs and sustainable programs that will give us sustainable changes. So I think sitting down and talking, looking at the data, and really developing strategies within your organization. Some organization structures look different than others, but there is a guideline on the CDC website that helps guide these type of conversations and creating these type of structures. So.
Thank you, Monica.
Oh, what a cutie.
Sorry, I don't know whose baby that is.
No.
So one other question is, what can we do differently to improve or enhance our ability to identify and understand that there are and what are the health inequities with our patients?
I can take that one. Oh, okay, go ahead, Veronica.
Maybe we can both tackle it. So you can go first, Monica.
Yeah, so I was going to say you can start by doing an assessment in your organization of where you are now. Are we getting another beautiful baby screen? Okay, Q&A. Yeah, so I would start by taking the pulse of your organization now and seeing where you are, right? What are your partnerships currently? Do they include any of the groups that have historically been at the bottom of the inequity scale? And so I would start there. And then you would want to know what your goals are, right, for your organization. Where do we want to end up? Where are our deficits? Where are we now? What are our deficits, and where do we want to end up? And from there, you can start to plan what your equity plan for your organization will look like.
Okay, thank you, Monica. And so just one more question, because we're a little bit over time, is how can we build better connections and collaborations with the populations that are experiencing health inequities?
I guess I'll answer that one. I think the first thing is to be willing, right? To be willing to go to places that you may not have an immediate return on your investment, so to speak. You know, we highlighted what we did in the community in East New York, Brooklyn, but what we didn't say was the amount of work we put into meeting with the community members of the church, making sure that, you know, they were very guarded as to what they wanted their parishioners to hear and like be subjected to. So it took us showing up on like weekends and on Sundays and on it to events that they were interested in, just so that we can let them know that, hey, we're here for you and we want to support you, so that we can kind of build trust, right? And we are Black women, and for that to be a barrier, you know, for that to be such so challenging for us, I can only imagine someone from another racial ethnic background having had that same type of opposition. But you have to be willing to understand that that is valid and really want to go into these areas and not just so that we can say we moved into East New York and we have a clinic and now we can like start to gentrify that area, but to really get to know them, get to know what cultural practices they do, get to know, you know, where they stem from, why they make the decisions that they make. You know, one of the biggest things is like clinic time, right? We all are in clinic usually 9 to 5, at the very latest 6. Well, guess what? A lot of people from these lower socioeconomic backgrounds can't take off for work to come to clinic. So what about, let's do clinic on a weekend. Let's do clinic in the evening. Let's try to think of ways that are outside of the box that we can be able to partner with these people in the community so that we can get them into our doors.
Thank you. Kathy, I'll hand it over to you now. Thank you, ladies. Great talk. Thank you.
Fantastic presentation. Thank you so much. And thank you, Margie, for moderating.
You're welcome.
Thanks to everyone who participated in session 3 of our Nurses Education Series. Everyone who attends today will receive an email that includes a link so that you will be able to view this webinar on demand. And you'll also receive a link to a program survey. The American Liver Foundation is always seeking ways to improve our educational programming, and your feedback is very, very helpful to us. So I thank you in advance for participating. When the details and the registration link are available for session 4, which we hoped will take place in October and will focus on the topic of liver transplantation, you will receive an invitation via email. If you are a healthcare professional and you are interested in serving on one of our 17 medical advisory councils across the country, please reply to the email that you received for today's webinar, and we will connect you with the medical advisory council in your area. I know we have people from all over the country who have tuned in today, as well as a couple of international visitors. So we're glad you're here, and we hope that you stay connected with us. For more information about liver-related health topics, I encourage you to visit the American Liver Foundation's website, liverfoundation.org. We also encourage you to share our website with your patients. Also, please note that the Liver Foundation recently established a Diversity, Equity, and Inclusion Council. If you would like more information, please contact my colleague, Ivory Allison, at iallison@liverfoundation.org, and Allison's with 2 L's. And lastly, we invite you to follow ALF on social media. So like us on Facebook, follow us on YouTube. We recently launched a professional education or a YouTube channel for medical professionals, and we're starting to upload a lot of our professional education webinars there. So it's a great resource for you, but also there are other videos on the regular ALF YouTube channel for your patients. So thank you again to today's moderator, Margie Fernandez-Sloves, and to our expert speakers, nurse practitioners Nicole Golden, Monica Cohn-Nelson, and Veronica Roy, and to the dedicated team of accomplished nurses in the American Liver Foundation's Greater New York Medical Advisory Council who planned the Nurses Education Series this year, including today's webinar. The planning team includes Margie Fernandez-Sloves, Deborah Gus, Diane Lapointe-Rudeau, Alyssa Sajays, and our newest member, Nicole Golden. A thank you again to our sponsors for today's program, ASI Oncology and Gilead Sciences, for their generosity in supporting the American Liver Foundation and our Nurse Education Series. This program has now concluded. We certainly thank you for attending and hope to see everyone at session 4.
Thank you, everyone. And thank you
Thank you, everyone.
Have a great day, everyone.
Thank you.
Thank you so much.
Stay well.